So the topic today is the new avenues in the management of advanced biliary tract cancer. And our chairman has already highlighted one of the important trial, TOPAZ-1 study, which also I will mention in my presentation. So these are my disclosures. So I will use next 20 minutes to briefly walk you through these 4 areas. First, background, but I won't speak too many because I know our Indian doctors are very familiar with the biliary tract cancer, especially the gallbladder cancer as mentioned by our chairman. I will give you some update on the first-line therapy, followed by some new concepts or some data in the second-line therapy before I end my talk with some future directions. So the background, we know that actually biliary tract cancer is not the commonest GI malignancy. It only occurs in around 3% of all GI cancers, but actually recently it's caught a lot of research attention. I think one of the reasons is because we do see more biliary tract cancer, especially intrahepatic cholangiocarcinoma, which you can see from the US data or from the UK data or European data on the right-hand side. You can see generally there's been gradual increasing incidence of intrahepatic cholangiocarcinoma. We don't know the exact reason. Our chairman has already mentioned maybe the gallstones, the stone disease may contribute to some of it. But I think one of the factors is the metabolic syndrome, like diabetes, obesity, which also may contribute to those liver malignancy, including the intrahepatic cholangiocarcinoma. In terms of treatment approach, we already learned also from our chairman that around 10% patients are surgical candidates, and we now have some adjuvant therapy like the BioCap study suggesting the capecitabine in prolonging the overall survival and the disease-free survival. Unfortunately, 80, maybe 90% of patients are the inoperable candidate, and they require some form of systemic therapy. Although traditionally, we learn from the literature, some centers may also apply some local regional therapy, for example, the Y90 or even some HAIC for the intrahepatic cholangiocarcinoma, like we treat the HCC. And also we know our radiation oncologist told us that maybe RT may help some cases, although the robust evidence are still lacking. And also we have learned from some serious and some prospective study that photodynamic therapy may be useful in extrahepatic cholangiocarcinoma. Although personally, I find the use of these type of local regional therapy quite variable, and is the use probably decreasing in the near future because of the advance of the systemic therapy. Then move to the first-line therapy. We all learned from the UK ABC O2 study, which established the gemcitabine cisplatin as the standard therapy for patients with advanced or locally advanced or unresectable biliary tract cancer. When you look at the overall survival, definitely it's better than the single agent gemcitabine, OS of around 1 year. But of course, this is far from satisfactory because we need better treatment for our patients to live with a median overall survival longer than 1 year. And also when you look at the response rate, is the partial response rate only around 1/4 of patients with responses. And also we learned from my experience that the response probably is not durable amongst those patients, even they respond to the chemotherapy. Anyhow, for the past over 10 years, this regimen has been the most commonly used regimen all over the world. And also, I think is also established as a reference control arm when we develop the first-line therapy for our patients. Are there any progresses in the past 10 years? There are some, but actually not many. For example, the Japanese group established the GEM-TS1 as a non-inferior to the GEM-cisplatin. And we also learned from these SWOG study, the phase 2 clinical trial, they used a triplet, gemcitabine, cisplatin, and adinab paclitaxel in the treatment of advanced biliary tract cancer. You can see from the waterfall plot and also from the response rate, it's quite impressive, 45%. And also you could see there's some patients with quite deep responses with a response shrinkage of tumor over 80 to up to 100%. But not surprisingly, this triplet regimen, chemotherapy regimen, is at a cost of a quite high, mainly marrow toxicity, with a 33% patient developing grade 3 to grade 4 neutropenia. Of course, this could potentially be relieved by the use of growth factor. And also you can see in this phase 2 study, the overall survival seems to be improved much better than the GEM-CIS in the UKABC study. But of course, we need to interpret this result with caution. It's only a single arm study. It may be a highly selected population. This is why this regimen is being tested now in a randomized study comparing to GEM-CIS. And hopefully in the future, we have a phase 3 readout to see whether this aggressive regimen could be used routinely in our patients in the first line setting. And our chairman has already very nicely alluded to a very important study, in my opinion, which is the TOPAZ-1 study. This study, actually quite a robust study, is built on the quite promising data from our Korean colleague. And then the sponsor and also the investigators has developed this phase 3 clinical trial. Basically, they included patients with ICC, extrahepatic, and the gallbladder cancer. The patient could have either recurrent disease or initial metastatic or local advanced disease. And the performance status 0 to 1. And the patient were randomized to 1-to-1 ratio. And the control arm is the GEM-CIS plus the placebo, while the experimental arm is on the durvalumab every 3 weeks in combination with the GEM-CIS every 3 weeks up to 8 cycles. And after completion of the GEM-CIS, the patients also will receive the maintenance durvalumab if they have a disease control or even partial response from the disease, while the placebo arm received the placebo therapy. And the primary objective is to demonstrate any difference, improvement in the overall survival, while other secondary endpoints are pretty standard with the PFS, response rate, duration response, safety, and also pre-planned analysis of the PD-L1 status impact on the outcome of the patients. I won't go into too much, bore you with all these details. I'm sure you can go back to the New England evidence paper, but we'll highlight several things in the baseline characteristics. First of all, you could see, actually it's quite a international study. Although 50% patient Asian, another 50% actually came from other parts of the world. I'm not sure if the Indian investigators, the site patient were grouped under the Asian. I believe so, but correct me if I'm wrong. And also you could see there's quite a well-representative populations with around 50% patient with ICC, around 20% extrahepatic cholangiocarcinoma, and 25% of gallbladder cancer. Most of the patients have initial unresectable disease, and also most patients have metastatic disease, but there are also some patients with recurrent diseases, and also patients with locally advanced diseases. Around 60% patients have the PD-L1 expression higher than 1%, while around 30% patients belong to the PD-L1 negative population. So this was the primary outcome of the patients. You could see it from the Kaplan-Meier curve. In terms of the median overall survival, there's been modest improvement of the overall survival, 12.8 months versus 11.5 months, with a hazard ratio 0.8, and also with statistical significance according to pre-specified p-value. But to me, the more impressive finding is that you can see after reaching the median overall survival, the curves continue separating between the experimental arm and the control arm. And you could see it result in, for example, in the landmark analysis, around 10% difference in the overall survival rate at the 18-month, actually close to 15 months at the 2 years overall survival rate analysis. I think this is a proof of concept that the continuation of the PD-L1 durvalumab could benefit the proportion of patients which is durable. And this is why you can see there's a continued separation of the survival curves. When you look at other secondary endpoints, for example, the tumor response rate, also there's a modest improvement in the response rate with around 27% patient having overall response from the combination, while only around 19% patients benefited, having a response from the placebo. And also when you look at the duration of response, again, you could see generally the experimental arm, they have a shorter time to the response and also slightly longer time of duration response. All these suggesting that these combination regimen are benefiting the patient with advanced biliary tract cancer. When you try to look at the subgroup analysis, generally you can see all the predefined subgroup, the development plus Genesis arm, they benefited all subgroup of the patients. Perhaps you can see some outliers. For example, in the region, generally you could see there's a trend that the Asian population, they tend to have more benefit from the rest of the world in terms of survival benefit. Of course, this is more hypothesis generating, but again, you can see the rest of the world, they also derive benefit. But probably there's some either genetic or tumor environment that favor better development response in the Asian subgroup. I think this is also observed in other liver cancer, like the HCC. And also when you look at the PD-L1, interestingly, although we do see a slight trend of the benefit favoring the positive PD-L1 subgroup, but also you could see the PD-L1 negatives group also benefit from the combination. And therefore, I think at this moment, we could not rely on just PD-L1 expression to decide give or not to give. Basically, we need to give to our patient if they could afford or if this is a reimbursable regimen. Perhaps I will stop at this first-line therapy and move to the second-line therapy. Of course, we could discuss more later about how we interpret these TOPAZ-1 data. I think second-line therapy is very crowded or very interesting now because we're generally moving from the blind chemotherapy, empirical chemotherapy, more towards the personalized treatment. And because we understand from the molecular analysis or NGS data that some driver mutations exist in the cholangiocarcinoma, especially, for example, in a hepatic, we have seen a patient around 10 to 20% having these FGFR2 fusions, and also these IDH1/2 mutations. And also in the extrahepatic or gallbladder cancer, we persistently see that around 10 to 20% of patients are having these HER2 amplifications, which may also sensitize patients to the HER2 therapy. Also, there's also some other tissue agnostic marker like the NTRK or the MSI phenotype or even BRAF, which will also subject our cholangiocarcinoma patients to some targeted personalized treatment. Perhaps this is a very busy slide, just showing you a snapshot of these biomarker or actionable mutation-driven clinical trial. On your most left-hand side, we have IDH1, which is ivosidenib. You can see, although the response was not very high, there was an overall survival benefit. And it's better than the standard second-line chemo, like the FOLFOX chemotherapy. And also in terms of FGFR2, we have pemigatinib and infigratinib. And I think there will also be some other FGFR2 inhibitor coming. All these showed in this selected population, there's a response rate around 20 to 30%. And this was also translated into improvement of the overall survival. I think also the HER2 therapy is very exciting now. Based on experience in the breast cancer and also gastric cancer or even colorectal or lung cancer, we already have a plethora of a different HER2 therapy, like the combination of pertuzumab plus the trastuzumab or some other new HER2 therapy on these patients. And also we have the drug conjugate. All these although the study is a single arm, small scale, but all these show a very high response rate, up to 40 or a high disease control rate. And also this seems to be translated into a survival benefit in this second-line population, which is again, apparently better than the patient treated with the chemotherapy. So hopefully in the future, we'll see more data with these biomarker-driven clinical trial. Perhaps you may also ask, we also use the immunotherapy in the second line. Unfortunately, the data is not that, I would say, more mixing or not that encouraging. One of the data come from the pembrolizumab, which is a combined analysis of the KEYNOTE-158 and the KEYNOTE-028, which is a basket study. But when they look at the role of the single agent pembro in advanced biliary tract cancer, you could see, okay, you still see some from the waterfall plot, some patients responding to the disease, but actually not many, maybe around 10, 20%. And also when you look at the overall, when you look at the overall survival and also the progression-free survival, is that OS is only around 7.4 months, and the progression-free survival is only around 2 months. This is actually quite a, I would say, not very impressive result if you talk about the single-agent pembrolizumab. And also, when you look at another study, which is it's a multi-center study of nivolumab in patients with a second or third line treatment of advanced biliary tract cancer, I think you can see the response rate is not very impressive. Central review only show around 10% patient responding to the treatment. And also, but the interesting finding is that they seem to suggest that the patient with a PD-L1 positivity seem to derive more benefit. But of course, this is a single arm study. We need to have a more robust, especially randomized data to see whether the PD-L1 is more a prognostic marker or really a predictive biomarker to the patients treated with nivolumab in the biliary tract cancer. But anyhow, I would say from these studies, single agent PD-1 probably is not very important, or I would say very effective in this setting. Then how about the combination? There have been one phase 2 study, I think it's by the US group, trying to look at the combination, the ipilimumab together with the nivolumab, the CTLA-4 and the PD-1. You can see the response rate seems to be better, now up to 30%. But this also at the cost of a higher immune toxicity, although they reported grade 3 immune AE around 50%. But I think when you use more generally in the population, perhaps we will see more IRAE in this population. And also this seems to be also translated into some improvement in the survival and resulting in some tail. But whether this regimen is could be routinely used in the population, I think again it requires some validation study. Maybe it can be used now as an off-label or in some really heavily pretreated patient while they're still fit for the immunotherapy. Last but not least, recently there have been one China study. Although it's published not a big journal, but actually when you look at the data, it's quite impressive. By use of the pembrolizumab together with lenvatinib in the refractory populations, you can see the waterfall plot seems to be better than the single agent the PD-1 nivolumab pembrolizumab. And also when you look at the OS in this heavily pretreated group, it's close to 1 year. Fortunately, we don't see any phase 3 data now. I know the MSD probably having some basket study of this combination in the biliary tract cancer. And hopefully in the future, we can have more international robust data to see whether this regimen could be generally useful in the larger populations of advanced biliary tract cancer. So probably I will move to the last session, which is the future. I think you already learned there's a lot of excitement about the targeted therapy, immunotherapy in the biliary tract cancer. Currently, in the first-line setting, we already have at least 3 clinical trials on the use of the FGFR2 inhibitor, TAS120, infigratinib, pemigatinib, versus the standard GemCis in this FGFR2 rearranged population. All these studies are ongoing, although I think they see a challenge of recruiting adequate number of patients because only around 5 to 10% patients in the real world have this FGFR2 fusion, and may take quite a long time to recruit these populations. And also, I think there's some study talking about the combination, similar to the TOPAZ-1 study with the GemCis. Unfortunately, this study has already prematurely closed. Perhaps we won't have these mature data or have a proof of this agent. Another study is the Pembro plus GemCis versus GemCis. There's some rumor that this study may be presented this year in the ESMO. But let's see whether we could see the data. And for the chemotherapy, we again, as mentioned, we have the SWOG study, the GemCis plus or minus nab-paclitaxel. But also we have some modified gem plus cisplatin ongoing versus the ordinary gem plus cisplatin in the first-line setting. Last but not least, apart from the first-line setting and also those are immunotherapy and FGFR2 inhibitors and the conventional chemo, actually, there's also highly exploratory approach, which is also ongoing in the biliary tract cancer. We may not see phase 3 data, but I think some of these early studies may potentially change our thought or prime the future phase 3. I think there are some study talking about the perioperative treatment in the, or even neoadjuvant setting in the cholangiocarcinoma. And I know there's some data, especially from Asia, China, CAR T cells may also be beneficial in some patients with a cholangiocarcinoma. Y90 plus chemo, I think recently our group has presented in the liver cancer journal that the combination of Y90 to chemo, GEM-CIS, may benefit some of the ICC patients. Last but not least, I think there's also some proof of concept study talking about the combination of target therapy and the PD-1 and PD-L1 antibody. This may potentially replace the standard chemo as the first line or treatment in the future. But this is highly exploratory. Hopefully, we have some more promising result in the future. So, in conclusion, ladies and gentlemen, I think the concept of the BTC treatment has been, I would say, evolving rapidly for the past decade. We're moving from the empiric chemo now to IO plus chemo, and also the personalized treatment. And also the field, I can expect, will be very competitive. And as mentioned, the Indian country, you have a lot of patients. I think certainly you can contribute to the development of this treatment, of the treatment in BTC. And there will be a lot of research questions for us as clinicians and as clinical investigators. So last, I am showing you the night view of Hong Kong. Hopefully, after the COVID pandemic, we could meet again, either in India or in Hong Kong, to discuss more excitement on the development. So thank you very much for your attention. I'm happy to discuss or address any question later. Thank you.